Imagine going to the doctor with what looks exactly like a severe bleeding vascular tumor,
Right.
but then you discover your skin isn't actually growing a tumor at all. It's basically collapsing from the inside out.
Yeah, it is a truly terrifying clinical presentation. I mean, when a patient comes in with these massive dark red blood blisters
Wow.
and, what looks like severe internal bleeding of the tissue, a clinician's mind naturally goes to some very dark, very urgent places.
Naturally. Well, welcome to today's deep dive. This is customized specifically for your curiosity about medical mysteries and, the hidden mechanics of human biology.
Absolutely.
We're examining a pretty hefty stack of clinical guidelines, pathology research, and some recent dermatological case studies.
Which are fascinating, by the way.
They really are. And our mission today is to figure out how clinicians actually diagnose and manage a highly deceptive condition. Specifically, the rare bullous or blistering and hemorrhagic variants of lichen sclerosus.
It's basically the ultimate diagnostic puzzle. We have a well-known disease putting on this really alarming disguise,
Right.
and it forces doctors to look past the surface level chaos, basically, to figure out what is mechanically failing at the cellular level.
Okay, so let's ground this first for everyone listening.
Hmm.
We know classic lichen sclerosus, or LS, is an inflammatory skin condition, right?
Correct.
The hallmark presentation involves these intensely itchy, ivory white, kind of parchment-like plaques.
Yeah, very thin, crinkly skin.
Exactly. And they notoriously appear in a figure-of-8 pattern around the anogenital region, though I've always wondered why that specific shape.
Well, it mostly comes down to anatomical vulnerability. That figure of 8 encompasses the vulvar and perianal regions in women, so areas subject to a unique combination of localized occlusion, friction, and, specific microbiomes.
Oh, that makes sense.
Yeah. While the exact trigger for LS remains elusive, I mean, it's likely a mix of genetics and a localized autoimmune response. But that specific anogenital environment seems to act as a catalyst for the inflammatory cascade.
The cascade that creates those classic white plaques.
Exactly.
And the skin in those plaques becomes incredibly thin. It loses its bounce. But our focus today is when this classic presentation takes a sudden, violent turn.
A very frightening turn for the patient, yes.
Right. Patients walk in not just with white plaques, but with sudden, massive hemorrhagic lesions just erupting across the skin.
And to understand that turn, we really have to look at the fragility of the tissue.
Because it's not normal blistering.
No, not at all. These blood blisters, they don't require major trauma. They can appear completely spontaneously.
Wait, really? Just out of nowhere?
Just out of nowhere. Or from the sheer force of simply sitting down in a chair or, just wearing tight clothing.
Geez. If just sitting down is enough to cause severe bleeding, the structural integrity of the skin must be entirely compromised.
It is entirely gone.
It reminds me of like a house where the foundation has been secretly hollowed out by termites.
Oh, that's a good way to put it.
Right. You walk by and it looks perfectly fine on the surface. Maybe the paint's a little pale, but the support structure is completely gone.
Exactly.
So the absolute slightest breeze, or in this case, the slightest friction from like denim jeans, causes the whole structure to just collapse inward on itself.
That termite analogy is absolutely spot on because in this scenario, the termites are the chronic, destructive, inflammatory pathways of lichen sclerosus.
That breeze.
The breeze that brings the house down is often the extreme pruritus or itchiness, which is heavily driven by the disease.
So the patient is essentially providing the breeze themselves by scratching.
Exactly.
Because the inflammation is actively sensitizing those local nerve endings.
Precisely. The localized immune response, it basically releases a flood of inflammatory cytokines.
Right.
And these cytokines, they don't just damage tissue, they heavily stimulate the cutaneous nerve fibers.
Oh, wow. So they can't help it.
No. The resulting itch is so profound that the patient is almost neurologically compelled to scratch.
Ram.
And that scratching applies sheer force to tissue that has absolutely no mechanical strength left, which leads to immediate hemorrhage.
Okay, so we see the Clax house on the surface. We see the bruising and the blisters. But I really want to know what's failing in the basement.
Let's look under the microscope then.
Yeah. What exactly are those inflammatory cytokines doing to the tissue down there?
Well, it's an absolute war zone down there. Under the microscope, classic lichen sclerosus presents with an atrophic epidermis.
So a severely thinned top layer of skin.
Right. But the real disaster is just below that, in the dermis. pathologists see a thick band of hyalinized sclerotic dermal collagen.
Okay, wait. I want to pause and hyalinize for a second,
Sure.
because we see that term constantly in the pathology reports. But what does it actually mean for the patient's skin in reality?
So hyalinized refers to tissue taking on a glassy, stiff, almost homogeneous appearance under the microscope.
Glassy and stiff, not what you want your skin to be.
Definitely not. In a healthy dermis, you have this beautiful, flexible lattice of normal collagen and elastic fibers. I mean, it's what gives your skin its stretch and its recoil.
It bounce.
Exactly. But in LS, an army of T cells infiltrates the upper dermis,
The termites.
the termites. They release chemicals that stimulate fibroblasts to pump out abnormal, rigid collagen.
Oh, so they're building bad foundation material.
Yes. While simultaneously releasing enzymes called matrix metalloproteinases.
Which chew up the healthy elastic fibers, right?
Exactly. They decimate the extracellular protein network, so the flexible lattice is just replaced by a rigid, non-compliant, glassy scar plate.
Yay.
And that is hyalinization.
Okay, that definitely explains the white, crinkly appearance on the surface. But where do the massive blood blisters come in?
Well, within that new rigid scar plate, the blood vessels are essentially stranded.
Stranded how?
When pathologists examine biopsies of these hemorrhagic variants, they find dilated, congested, and focally thrombosed vascular channels.
Clotted vessels.
Right. And these vessels are practically shoved right up against the thinned-out epidermis, completely unprotected by any elastic tissue.
Wow. And the sources note that structurally, this cluster of dilated, clotted blood vessels pressing up against the skin, it perfectly mimics an angiokeratoma.
Which is a benign vascular tumor, yes.
Right. So let me challenge this for a second. Is the body actually forming a new tumor in response to all this trauma, or is this just like a trick of the light?
It is entirely a trick of the pathology. There is no tumor growth whatsoever.
Okay.
It is a profound mechanical failure. Because the vessels are trapped in that rigid, hyalinized collagen, they just cannot expand and contract normally.
They've lost all their shock absorbers.
Exactly. So when normal venous pressure increases, say when the patient literally just stands up or experiences mild friction, those thin-walled vascular spaces simply balloon out.
They dilate, fill with blood, clot, and boom,
Yeah.
you have something that perfectly mimics an angiokeratoma.
But is actually just a structural blowout.
A blowout.
The loss of support combined with localized trauma creates a blowout. It is a pure architectural collapse.
Which brings us to the diagnostic labyrinth. Because this structural blowout perfectly mimics a whole host of terrifying conditions.
Oh, it really does.
If a patient presents with massive, dark blood blisters on their skin, how does a clinician know it's a mechanical blowout from lichen sclerosus and not, say, a primary autoimmune attack?
Well, the differential diagnosis is a minefield. Clinicians must immediately rule out severe autoimmune bullous dermatosis.
Like what?
Conditions like bullous pemphigoid, pemphigus vulgaris, or mucous membrane pemphigoid.
And those are diseases where the body produces autoantibodies that actively target and destroy the glue holding the skin layers together, right?
Exactly. They also have to consider bullous lupus, bullous lichen planus, and even severe systemic reactions to insect bites.
That is a very crowded field of imposters.
Very.
And the treatments for all those conditions are radically different. You can't just guess here.
You certainly can't guess.
Yeah.
So the first step is often dermoscopy.
The magnifying tool.
Right. Using that specialized tool, the dermatologist scans the hemorrhagic lesion looking for context.
What kind of context?
They are searching for the multicolored, diffuse hemorrhagic area, the blood blister itself, but specifically they want to see if it's sitting alongside classic LS clues.
Like the ivory white patches we discussed earlier.
Yes, the structureless white patches, and notably something called comido-like openings.
Wait, comido-like? Like blackheads?
Similar visually, yeah. These are essentially follicular plugs, hair follicles packed with keratin debris.
Okay.
They are highly characteristic of LS, so if you see severe bleeding right next to those plugs, the compass points heavily toward lichen sclerosus.
But a magnifying glass is not a definitive diagnosis, especially with stakes this high.
Definitely not.
We had this fantastic cross-sectional study out of Vietnam in our sources.
Oh, yeah.
And it highlights the absolute necessity of a very specific pathology tool to solve this puzzle. Direct immunofluorescence, or DIF.
Yes.
Let's dig into the mechanics of DIF, because it is just brilliant.
It really is one of the most elegant tools in dermatopathology.
How does it work?
Well, when a doctor takes a skin biopsy, Standard practice is to drop it in formalin to preserve the structure.
Right, the usual biopsy jar.
But formalin destroys delicate immune proteins. So for a DI test, the biopsy is actually snap frozen.
Yeah, not frozen. Sure.
This preserves any rogue immune complexes exactly where they landed in the tissue.
And then the lab brings in the glowing trackers.
Exactly. The lab applies a solution of antibodies that have been tagged with a fluorescent dye.
So cool.
And these tagged antibodies are specifically engineered to seek out and bind to human immune deposits, most commonly immunoglobulin G, or IgG, and a protein called C3.
And C3 being a key player in the complement system, which is essentially the immune system's amplifier cascade.
Correct. So if a patient has a primary autoimmune blistering disease like bullous pemphigoid,
Yeah.
their own immune system has deposited IgG and C3 right along the basement membrane.
Which is the exact junction between the epidermis and dermis.
Right. So when you look at that frozen tissue under a fluorescent microscope and you shine the right wavelength of light on it, the dye activates.
And the tissue literally lights up.
It lights up like a neon sign. Pathologists look for specific glowing patterns.
What kind of patterns?
Well, a sharp glowing line right along the basement membrane indicates a linear pattern, which is classic for pemphigoid.
Okay.
But a speckled starry sky look indicates a granular pattern, which is often seen in lupus.
This makes the diagnosis so clear. I mean, if a patient has severe blood blisters and the DIF test lights up with those linear or granular deposits, you are definitively dealing with a primary autoimmune blistering disease.
Yes.
The body is actively attacking its own cellular glue.
But if the DIF test stays dark,
Yeah.
if there's no glowing pattern at all,
Then there is no primary autoimmune attack on the basement membrane. The blisters aren't being caused by rogue autoantibodies dissolving the glue.
exactly. Combine that negative DIF with the classic hyalinized collagen and those ballooned out vessels on the regular biopsy. And the clinician has definitively caught the rare bullous variant of lichen sclerosus.
The negative DIF is essentially the ultimate proof of our termite analogy.
Yes.
It proves the blistering is a secondary mechanical failure. It's caused by the structural degradation of the dermis, not a primary attack on the adhesion molecules.
Perfectly stated.
Okay, so the clinician has navigated the labyrinth. They've ruled out all the autoimmune imposters.
They have a confirmed diagnosis.
They have the infirm diagnosis of bullous or hemorrhagic lichen sclerosus. Which brings us to, honestly, the most urgent question for the patient in the room.
Treatment.
Yeah, how on earth do you treat this? How do you treat skin that has lost its structural integrity and is actively tearing open?
So we turn to the clinical guidelines for this, specifically the British Association of Dermatologists, the BAD, and they outline a very strict evidence-based approach. The gold standard first-line therapy is a 3-month regimen of an ultra-potent topical corticosteroid.
Specifically clobetasol propionate, right?
Yes, clobetasol propionate 0.05% ointment.
Following a very specific step-down protocol, too.
Right. Once a day for a month, alternate days for a month, then twice a week.
Okay, I have to stop you here because this is where the logic completely breaks down for me.
How so?
The gold standard treatment for skin that is already paper thin, that is literally blistering and bleeding because it has lost all its collagen and elastic support,
Yeah.
is an ultra-potent steroid.
I know, it sounds counterintuitive.
It sounds crazy. We know that prolonged use of strong steroids causes skin thinning and atrophy. Applying that to skin that is already collapsing sounds like throwing gasoline on a fire.
It is arguably one of the greatest clinical paradoxes in dermatology, and honestly, it's a very common point of anxiety for both patients and newer clinicians.
I can imagine.
Under normal circumstances, on healthy skin, you're absolutely right. Long-term use of ultra-potent steroids downregulates collagen production and thins the skin.
Exactly.
But you have to remember what is currently happening in the specific microenvironment of an active lichen sclerosus lesion.
The localized inflammatory cascade.
The inflammation is the driver of all the destruction. The T cells are pumping out cytokines that are actively instructing the tissue to scar and simultaneously chew up the elastic fibers.
Right, the termites are actively chewing.
So clobetasol propionate doesn't just sit on the skin. It penetrates the cells, binds to glucocorticoid receptors, and literally moves into the cell nucleus.
To do what?
To switch off the genes responsible for producing those destructive inflammatory cytokines.
Oh, wow. So it acts as an exterminator at the genetic level.
It completely shuts down the termite activity.
That's incredible.
When you halt that profound destructive inflammation, you stop the abnormal scarring process. You stop the degradation of the elastic fibers.
So, paradoxically, by stopping the inflammation, the ultra-potent steroid doesn't thin the skin further.
No, it actually rescues the remaining architecture.
It allows the tissue to begin a normal healing process.
Exactly. It prevents the formation of new blisters by protecting whatever structural integrity is actually left.
So the disease is doing infinitely more damage than the side effects of the drug ever could.
Far more.
The drug essentially acts as a shield.
Yes.
But management can't end with just a steroid ointment, right? Especially when a patient is presenting with open hemorrhagic blisters.
No, holistic barrier management is absolutely critical here. Because the structural integrity is so compromised, patients must aggressively protect the skin from any friction or moisture damage.
What do the guidelines recommend for that?
They recommend the liberal use of heavy barrier preparations, things like yellow soft paraffin.
And I imagine hygiene routines have to completely change as well.
Completely. Regular soaps contain surfactants that strip the skin's natural lipid barrier, which causes severe irritation.
Right.
So patients must switch entirely to gentle soap substitutes.
Makes sense.
Furthermore, as we discussed with the triggers, avoiding all physical irritants is mandatory.
So no tight clothing.
No tight clothing, no synthetic fabrics, or activities that create shear force. You have to prevent shearing the fragile skin while the steroid goes to work.
And with open wounds and blisters, infection must be a massive, immediate concern for the clinician.
It requires extreme vigilance. You have ulcerated skin sitting in an area of the body prone to warmth and moisture.
A perfect breeding ground.
Clinicians must constantly monitor for secondary infections. Staphylococcus aureus, Candida species, or even the herpes simplex virus can easily invade these open hemorrhagic plaques.
And a secondary infection doesn't just complicate healing, does it?
No, it can trigger further localized inflammation, completely undermining the steroid treatment.
It sounds incredibly intensive. And even after that 3-month steroid regimen, even after the blood blisters heal and the inflammation is suppressed, the clinical guidelines make it very clear the journey isn't over.
Sadly, it's not. Lichen sclerosus is a chronic, lifelong condition.
Yeah.
It requires long-term maintenance therapy, often continuing that twice-weekly steroid application indefinitely and lifelong follow-up.
But there's a much more serious reason why a patient with a history of bullous or hemorrhagic LS must remain under a dermatologist's watchful eye. Right.
There is the risk of malignancy.
Yeah.
Patients with lichen sclerosus carry approximately a 5% lifetime risk of developing squamous cell carcinoma, which is an invasive skin cancer.
Why does that happen? I mean, is it the disease itself turning the cells cancerous?
It's basically the chronic inflammation and the resulting scarring.
Okay.
Tissues that are trapped in a cycle of constant damage, chronic immune cell infiltration, and chaotic repair, they are highly susceptible to cellular mutations.
That makes sense.
The squamous cell carcinoma very often arises directly on the areas of skin that have been heavily scarred or chronically ulcerated by the LS.
So regular, rigorous monitoring is non-negotiable.
Non-negotiable. You have to catch any malignant changes at the earliest possible stage.
So bringing this all together, we started with a truly terrifying presentation.
Very terrifying.
Sudden blood blisters and hemorrhagic plaques masking themselves as vascular tumors or severe internal bleeding. But by unpacking the histology and the diagnostic logic, we found the hidden mechanics beneath all that chaos.
We really tracked the pathogenesis, from the initial T-cell assault to the hyalinization of the collagen, right down to the mechanical failure that forces those trapped blood vessels to balloon out when their elastic support is destroyed.
We saw how brilliant diagnostic tools like snap-frozen direct immunofluorescence allow clinicians to hunt for glowing immune complexes.
And definitively separate a mechanical structural collapse from a primary autoimmune attack.
And we resolved the ultimate clinical paradox, how an ultra-potent steroid, a drug notoriously known for skin thinning, is actually the precise molecular weapon needed to shut down the destructive cytokine cascade.
And allow that fragile skin to survive.
It's a profound testament to how intricately balanced our biology really is, and how catastrophic it is when just one element, like our elastic support network, is compromised.
Absolutely.
Which leaves me with a final lingering thought for you to ponder today.
Building on the mechanisms we've discussed.
Exactly. We've just spent this entire deep dive exploring how lichen sclerosus so thoroughly dismantles the skin's extracellular matrix that it forces normal veins to balloon out and mimic tumors.
Right.
The body's own immune system essentially hollows out the structural foundation of the tissue.
A highly localized, highly destructive process.
Exactly. So, if researchers can unlock the precise genetic or cellular triggers that cause these specific T cells to target and degrade elastic tissue in bullous LS,
Yeah.
what other secrets might this rare variant hold? Could studying this localized failure teach us how to prevent or reverse the degradation of connective tissue in other parts of the body?
It's a fascinating prospect. I mean, if we understand the destruction, can we understand the preservation?
Exactly. Could mastering the extracellular matrix breakdown in lichen sclerosus eventually unlock new understandings of how our entire vascular system ages?
Or how systemic connective tissue disorders might actually be halted?
Yes. Sometimes the rarest, most alarming anomalies provide the brightest flashlights into the dark corners of human biology. We want to thank you for joining us on this customized intellectual journey. It's been great. Keep asking those deep questions about the complex mechanics of the human body, because you never know when a hollowed-out foundation might just teach you how to build a stronger house.